Chief McKern.
Tim
Tell us
McKern,
anything. Sorry, tell us anything that you'd like the group to know as well.
Tim McKern, Quilcene Fire Rescue, and welcome to the group. And I think it's still going to be rainy and windy out there, so I think fire season's far from beginning.
You shouldn't have said that.
Oh, I know.
Jinx it. How about Colleen?
Hi, my name's Colleen Rodriguez, and I'm the EMS training coordinator for the county. But since this meeting, the hospital has asked me to also join the meeting as the behavioral health person, because I'm the clinic manager for a couple different primary care clinics for Watership and Townsend, but I also am the behavioral health team clinic manager as well. So I work with Ann Kuman and Dr. Heastand and our licensed clinical social workers. So kind of networking, there's kind of a lag with us in the clinics with what you guys do in the community. And we're hoping to kind of bridge that gap a little bit. So I know that we've had other parties from the hospital on, but there's been a disconnect. So now that I'm on, they're like, oh, well, let's kind of connect the pieces. So that's why I'm here.
That's really good. Thank you. And we're excited to have that shoring up of some of the shallow spots. Molly.
Hi, everyone. I'm Molly Martin. I'm the executive director for the Jamestown Healing Clinic, which is the new opiate treatment program opening in Sept. And I'm pleased to join you all today.
We're really happy to have you here and looking forward to your presentation. Gabby.
Gabby Caudell, I'm the clinical director of Believe in Recovery and the RSAT program within the jail here.
Any updates besides I owe you a boot?
Yes, you do. Nope, just still waiting on our license from the state for a mobile unit. That should be here sometime soon. I'm gonna call them tomorrow and check on the status of that. Lots of exciting things are happening, but none that I can talk about right now.
Okay, well, we'll all stay tuned. Denise.
Yes.
Hi, I'm Denise Banker, the Community Health Division Director at Jefferson County Public Health, and I can't think of a new thing on my radar at the moment, but maybe Apple Martine will have a new thing that she can mention.
Okay, well, I'm going to go in the order of my squares, so hopefully I don't miss anybody. So Apple will get to you soon here. Beth Myers.
Hi, everybody. I'm Beth Myers. I'm the MAT SUD coordinator at Jefferson Healthcare. Just refining services and our ability to help people get to the places they need for recovery, mental health, and substance use therapy. Yeah, that's about it for now. Thanks.
Well, thank you, Beth. We're glad you're here. Anya?
Hi, I'm Anya Callahan. I'm a local social worker and I'm a consultant with the Behavioral Health Consortium working on overdose prevention, education, and outreach. I don't have any specific updates right now. Thank you.
Thanks. Apple?
I wear my glasses, but they're rainy. I just came in from outside. It was off-site at a visit. Hello, everyone. I'm Apple Martine. I am the director at Jefferson County Public Health. I have a nursing background and happy to be here representing JCPH. Just quickly, we have some positions available and I'm shamelessly advertising anywhere I go. I know you all have that same probably wrap as well. We're looking for a finance manager, a medical assistant for our sexual and reproductive health clinic, as well as a communicable disease nurse. So fascinating work here, so many cool things to do, so many different skills to learn. Spread the word. Our job postings are at the county website under the employment tab. I also will say about staffing, it's on my mind a lot. There is some foundational money coming through the state that will help us as public health across the state kind of expand some of our capacities. And we're really excited to have learned about that. It's been ongoing and being mounted for like the last 20 years. And it's finally, some of that money is finally being released. And so we have some internal excitement, especially about filling some gaps that we've never had people in positions for. So, you know, one of those things might be to enhance our epidemiology and how we do assessment and add that quality, which we've never had internally, to things such as what Lori does, and just really fine tune how we handle our data, which we have so much of. So those types of things are exciting. They're to come. So they're not full-fledged yet. Other than that, some managers in my team and myself went to Leavenworth this week for a Washington Association of Local Public Health Officials, and had a lot of after action reviewing to do on the pandemic. That doesn't mean after as in the pandemic's over, but in public health, we have so much to think about and recapture, reflect on, and then change, because we're not necessarily going to see a long bit of years pass between pandemics, unfortunately, with climate change and all the other things that are at play. So that was really fruitful for me. Reflective skills might not be as easy as you think. And so doing that on the scope of a pandemic that's affected everyone is quite a task, but I find it super interesting. And I hope we can share out some of that learning with everybody eventually. Thanks.
Thanks, Apple. Kelly.
Hello, good afternoon. Kelly Parcher, Executive Director of OWL 360. And next to me.
Hi, I'm Donna Markland. I'm her assistant.
We're a team working on some things. I think probably some exciting news for us to share, and would love to partner with many of the folks in the squares here we're seeing, is we just received a grant from Olympic Community Health, which was filtered down, I think, from like Regency Health Solutions to reduce stigma for substance use disorders for youth and young adults in our community. So if we haven't already reached out to you, or you haven't reached out to us, we'd love to kind of partner with you and talk about like how we just kind of work together as a team to reduce that kind of stigma.
Great, thank you. Good to have you both here. Alex.
Hey everybody, I'm Alex Lockwood. I'm the new project manager for the REAL team out of Jefferson County. I've only been here for about a month, so I'm orienting myself with the program and getting to meet a lot of you all on this call. And I'm just really excited to be here, and thank you all so much for your hard work out here.
Good to have you here, Alex. Adam.
Adam York, data analyst at Jefferson Healthcare. So much going on. I don't know where to start. Just buzzing in the county, just putting data together.
Oh, we're glad you're on it. Thank you, Adam.
Yeah.
If somebody's on it, you want it to be Adam. Jim Novelli.
Jim Novelli, Executive Director, Discovery Behavioral Healthcare. And just to follow with Alex, we got the grant again for the REAL program, which is for the next 2 years. So I'm happy about that, and then hopefully expand those services. On top of that, in May, we worked really hard and we submitted a RFP proposal to the SAMHSA for become a certified community behavioral health clinic. Hopefully it'll get us $4 million for the next 4 years. The goal is to expand our services, to do more, get better access to our services. And my hope is to have primary care under our roof with that grant. So the individuals who serve can access primary care and get all their needs met in one basically area. And we can do better care coordination and better, whole person care. So hopefully we'll hear something before soon, because the way the project starts, it should start by September 30th. So hoping to hear in August. We have a colleague of mine down in Port Angeles is on her second year of being a CCBHC, and these clinics are actually sprouting out all over the country. There's about 428 of them in 26 states. And so hopefully we can join that. I think this is the wave of the future and how behavioral health is going to be done. And so the feds are very interested in this model. Well, I've actually been funding these models. The state is now very interested in becoming more invested in creating these certified community behavioral health clinics. So it'll be a big step and it'll be a great thing for this community. So.
Okay, well, we'll look forward to hearing.
Yep.
Thank you, Jim. Dunya?
Hi, everyone. Dunya Fo with Jefferson Healthcare. Good to see all of you again. I actually had a question for you, Jim, so I'm glad that I went right after you. Some of the stuff that we have right now, though, is we're dealing with some difficult to discharge patient issues, a lot of advocacy work here in the off season. We did hear today that Senator Cant will push forward our cancer treatment project for $2.5 million. So we're really excited about that. So keep your fingers crossed, send us good thoughts. A lot of the folks on this call signed letters of support for that, and I really, really appreciate you as partners. One of the things that we talked about today with WISHA is a 23-hour drop-in outpatient crisis stabilization center. Jim, have you been watching that, and do you think that we're going to get something like that here? The conversation was focused on the that it's a voluntary drop-off. There is no ability to ITA, but is that something that we might bring to this community?
It's something we could look at. I think we were looking at this months ago or years ago as a crisis stabilization kind of unit, where people can come and stabilize. The question is, do we have the demand for that and to operate it as a 24/7 operation? And it's the staffing part that becomes something to really think about. And really, it's not as simple as it sounds.
Doesn't sound simple at all.
It's something I think we'd like to move towards. I know Commerce is putting money out there for lots of facilities, but the issue is becoming that they're putting money into building facilities, but there's not the staff to run them or the money to provide the direct services. And that's really where the struggle is. And so that I spent the whole day with the Washington Council for Behavioral Health. I'm a board member, and we were just meeting about all these issues and how to really disperse these funds and create services. They keep adding service lines, but we're really dying with staffing right now and really finding the appropriate staffing to do the jobs with. So yeah, I'd love to have something like that. I'd love to have a crisis stabilization unit. I know I talked to Lori when I first came on. I mean, that's what this area BHC started working on. But when I look at the numbers and the demand, I don't know how many people would really utilize it, especially when you have to staff it 24/7. But always open as we move forward. And if we become a CCBHC, we're going to have more access to be able to do more things too. I mean, now that we have SUD under our roof and we're doing MAT also, I think we'll be able to maybe look at a way that we can build that in. Absolutely.
I'd love to talk to you about it offline, maybe more in depth before I take a position with WISHA, because they are going to look to advocate for a few things, including additional funding. And I just don't know how much will make it into the rural areas, unsurprisingly. But yeah, let's talk. Thank you.
Yeah. All right.
Sorry to butt in, but the sheriff's office would be very interested in if there's anything we can do or being part of that. Jim's exactly right. And we looked at this before, but the numbers don't quite add up. But it is something that's been needed forever here. So solid. Thanks.
Thanks, Sheriff.
Good stuff. Jake, and before you go, we're going to kind of screen through the rest of our introduction so that we can keep on and get everything in the next 45 minutes that we have on the agenda. Go ahead, Jake.
Quick. Jake Davidson, Jefferson Healthcare. Thanks, everyone.
Good to have you here. Brian?
Hey, Brian Richardson with Deaf House Recovery Cafe. Tomorrow we've got a documentary screening, The Wisdom of Trauma, at 1:30 featuring Dr. Gabor Mate. And then at 6 p.m. we have open mic. Pray for sunny skies.
Okay. Chief Black?
Fred Black with East Jefferson and Port Lolo. Really glad to be here and happy to participate with the real effort. A couple people in our organization are part of that, and yeah, thanks for the invite, Alex. And then we are wrapping up our strategic plan standards of cover process. Many of you on here were part of that process as well, and we're learning what we didn't know before, but had assumed in a lot of ways. And the result will clarify and refine our core mission and capability. So thank you in advance.
Thank you. Good to have you here. Joey.
Hi, everybody. My name is Joey. I'm the Regional Director for Olympic Ambulance. My role with all of this is really, I'm kind of pioneering the charge in Washington State on alternative transport for mental health and substance use disorder. And I'll probably cover more of that on a different day. So
Okay.
happy to
And
be
I know
here. Thanks.
I owe you an email too, Joey. Richard.
All right, so Richard Davies, I'm a public defender here in town. Our office is downsizing. That's a good thing because it means that criminal legal system is getting out of the business of what I would consider public health. Thanks.
Okay, we'll look forward to hearing more about that. Lisa.
Good afternoon, everybody. Lisa Ray Thomas with the UW Addictions, Drug and Alcohol Institute and also the American Indian Health Commission. And we just finished our 3rd annual Transforming Our Communities, Sharing Innovations to Reduce Harms for People Who Use Drugs. Lori represented all of you beautifully on a panel about creating coalitions to inform policy. So thank you for all that work. And we just launched an announcement about a tribal sovereignty in the Indian healthcare system series. So I'll send that to Lori to forward to all of you. Thank you and congratulations on all your great work.
Thank you, Lisa. And I will make sure that email gets forwarded. We are very happy today that Molly Martin was able to come and give us an update on the Jamestown Healing Clinic. And Molly, I can run the slides here, or you can run them there, whichever is easiest for you.
Why don't you run them there? I have about 1 million screens up in the background and it'll take me forever to find them.
Okay. Can folks see that? Perfect. And then I'll turn it over to you, Molly.
All right. Well, thank you all for inviting me to speak here. I really appreciate it. I think I talked with you guys last August or so about the Jamestown Healing Clinic that we've been working on, which is a comprehensive opiate treatment program that offers wraparound services to individuals in Clallam and Jefferson County who have opiate use disorder. We are still waiting to open. Unfortunately, our application with all of our inspections and things like that is sitting on somebody's desk at the DEA in Virginia. And until they give us our approval number, we're not able to truly be an opiate treatment program. Although with all of our certifications, we can be a primary care facility and do several other things. So if they don't get us our numbers soon, we're probably going to start letting people who want to be a part of the OTP once we open come to us for primary care and some other services in the meantime so that we can sort of fast track them once we do get that license. We are here to serve both Native and non-Native residents of Clallam and Jefferson counties. So my hope today is to just sort of go through and dispel some of the myths that may surround our clinic and what we can and cannot do. And that's one of the big ones, is that people think that because we're owned by the tribe, that we're only here to serve tribal citizens or Native community members, and that's not the case. We are here for everybody. And so once we get our doors open, we would love to see patients who have opiate use disorder and want to be on treatment like methadone that involves daily dosing. Our tentative hours will be 6 a.m. to 2 p.m. Monday through Friday, and then 6 a.m. to 10 a.m. on Saturdays for dispensing. And if you don't mind going to the next slide, Lori, I'd like to talk a little bit with everybody about what an opiate treatment program actually is. That's another area where there can be some misunderstanding about what we do versus what like office-based treatment programs that prescribe Suboxone do. So opiate treatment programs are heavily regulated facilities that are regulated by the Washington State Board of Pharmacy, the Washington Department of Health, the State Opiate Treatment Authority, SAMHSA, as well as the DEA. So I have a lot of people who I'm reporting to on a daily basis, in addition to my bosses. But all of that comes with a lot of responsibility due to the medications that we prescribe. And we will do daily dosing of methadone So we are sort of the newer version of what people used to call a methadone clinic. And that means that patients with opiate use disorder can get started on the old school term used to be opiate substitution therapy, but really we all call it medication for opiate use disorder now. And they come and see us every day to get their medication dose, do things like counseling, as well as some of the other required things that are things like group counseling, as well as behavioral health evaluations and certain aspects of medical care associated with the use of methadone or daily dosing of Suboxone. And then we, in addition to the OTP, have expanded our services to offer a lot of really great wraparound services to help support people in recovery, since we know that it's not just medications that help people heal. There's a lot of other things that go into it too. When patients first join our services, they have to have a full ASAM SUD assessment, a medical evaluation, an observed urine drug test, and blood work. And that's all before they're able to get their first dose of medication. That typically means that an intake for somebody joining us takes about 4 hours. So patients, although we will have walk-in hours, it's not like a quick stop in, get an assessment, get a medication, and head out the door. This is a big time commitment for people because after that first 4-hour assessment, it means that they're coming back to us 6 days a week for dosing until they either are able to earn some extra take-home doses months down the road, or until there's some other service that they end up deciding to utilize instead. So we may see patients for years and years taking doses almost daily. We are not able to see patients who do not have opiate use disorder. So we know that there are lots of people in our community who have a variety of substance use disorders, and we would love to be able to help absolutely everyone, but we're starting with opiate use disorders because we are an opiate treatment program. We'll treat people who have other concurrent substance use disorders, but if somebody is, say, only using methamphetamine or only using alcohol, we would not be the primary treatment program for them. We also are not an inpatient treatment center, and we are not a detox center. So those are very needed services within our community, but our services here are for patients who are stable enough to be able to come daily for outpatient opiate treatment. All right, if you can go to the next slide. Okay, so what really is daily dosing? A lot of people have questions about this. So typically this means, like I said, that patients come to us 6 days a week for an observed daily dose of methadone or Suboxone. All of the methadone that we dispense here is dispensed as a liquid. It's cherry flavor. It is a teeny tiny little amount in the bottom of a Dixie cup that they drink and then have to follow it with a cup of water to make sure all the methadone has actually been ingested. And then they stay with us for a period of observation and are able to either go to whatever their next appointment is in our clinic or go about their day if that was all they needed to do that day. Suboxone is a film that they would take every day observed in front of the nurse as well. And then most patients who are coming to us, since we aren't open on Sundays, are able to qualify for what's called a take-home dose or a carry, which means that they get a lockbox that has 1 dose in it for Sunday, and they get that on Saturdays. And we have to provide justification to SAMHSA that for each individual patient who gets that take-home dose, that we have good reason to believe that the benefit of getting that dose on Sunday, so the benefit of not going into withdrawal, outweighs the risk of diversion or overdose of that particular single dose of medication that they got. There's 8-point criteria that we have to follow for patients to be able to earn additional take-home or carry doses. And we can go to the next slide there, Lori, because I think I've got it. Okay. I won't go into all of this in detail, but as you can see, patients have to follow all of these regulations and or all of these guidelines to be able to earn additional take-home doses beyond that Sunday dose. And if they're following all of this, every 90 days, they can earn one additional take-home dose. And it can't be given to them next to a day where they already have a take-home dose. So like if they were coming in and they had earned 2 carries, it couldn't be for like that they get them for both Monday and Tuesday. One day would have to be for Monday and one day would have to be for like Wednesday or Thursday. So this, contrary to what some local opposition had to say about us, we are far from being a dose and go and handing out methadone on every corner. That there's a lot of very strict guidelines that we have to follow for how we do this, and how to ensure that the individuals who we prescribe this medication for, as well as the community, is safe. So if you don't mind going to the next slide, and you can see here, this is sort of the take home maximal schedule for medications. Over the span of about 2 years, patients go in different phases. And if they meet that 8-point criteria that was on the prior slide, this is how they're able to earn take-home doses over the span of 6 different phases. So after they're involved with us for 2 years, theoretically, if they met all those criteria for 2 years, they would be able to earn 13 take-home doses to where they're only seeing us every other week. Most people, it takes far longer than 2 years to actually reach that stage though. Okay, we can go to the next slide. All right. Oh, I may have included take-home eligibility twice. Sorry about that. So talking about some of our wraparound services that we have, these are near and dear to my heart because I am a primary care clinician. I'm a nurse practitioner and was an RN for a long time. And I know how important it is for patients to have a holistic approach to their health, especially their physical health, in order to, well, physical and mental health, I should say, in order to promote recovery. So we have primary care available. We will, if people need to have a primary care clinician assigned to them, if they don't have a regular doctor, we can become that for them. Or if they just need to come to us for OTP services, we can do that too. But we'll have treatment for acute and chronic diseases. We'll have preventative health care. And then we will also have an on-site hepatitis C treatment program where the daily dose of their hep C drugs are given at our dispensing window. And the data with that and other programs who do this is shown to be incredibly successful, with opiate treatment programs actually having a higher hepatitis C clearance rate than some gastroenterologists. So we're really excited to be able to start doing that. We'll have behavioral health services on site, including in-person individual and group behavioral health counseling, substance use disorder counseling for individual and groups. We will have psychiatric evaluations 1 day a week for medication evals and med management and management of serious mental illness. We do not have inpatient psych services, DCRs on site, or after hours psych call. So there has been some confusion with the talks of the Jamestown tribe building a small 16-bed psychiatric hospital. That is not us, as far as not our building, but it will be eventually on our same campus. That's a couple of years down the road though. We have naloxone distribution here. Patients can actually get bottles of Narcan at the dispensing window when they're in for methadone or Suboxone dosing. We have nurse medical case management. We have dental care on site, which is to me a real game changer. I'm still in awe of the dental equipment that's here. Maybe it's because I'm not a dentist, but it looks incredibly fancy to me, and I'm really excited for us to be able to start using it for our patients. For dental services, so often we find that people who have substance use disorders have not had access to dental care in years and years. And not only being able to like treat infection and bring them out of pain, which is great all in its own, but being able to help somebody restore their smile to improve their self-confidence and get them back out in the community where they're not afraid to, like apply for jobs or get back in school. That is a really powerful thing that I'm very happy we're able to do here. We have transportation vans that are 15 passenger vans that will do transport to and from clinic here. And we need to pick patients up at their place of residence, bring them here to treatment, and then we have to take them back to the same place where we picked them up. We are not public transportation, so people who are, say like need to go grocery shopping or something like that afterwards, we would not be able to provide transport for that, but we are able to bring them to and from clinic from their home in either Clallam or Jefferson County. We have child watch services as well. We are not a daycare, but we are able to watch children for our clients while they are here getting treatment. And we can do that for up to 3 hours a day, Monday through Friday. We don't have child watch on Saturday mornings, but Monday through Friday during our open hours of 6 a.m. to 2 p.m., people can leave their kids with us for 3 hours while they get treatment in our office. And then we have lots of other connections to community resources and have as closed loop a referral system as possible in such a wide service area with so many different service organizations. But we try to keep a pretty robust list of where we can refer patients to for any other needs that they may have in their county of residence. Okay. So we can go to our next slide. So referring a patient to us, I will bring referral information, or my staff will, to a variety of organizations as we get closer to our opening date. So you have handouts and referral cards and all sorts of good stuff that you can give to clients. But the primary thing is that the clients who we see do need to have opiate use disorder, and they need to be willing to voluntarily join our services. Once we open, we do encourage patients to call us themselves rather than asking somebody else to call for them. If the patient is able to call, we'd like to speak to them so that we can verify that they are eligible and that also that they want to join us. If you have an urgent referral for a patient who is pregnant or somebody being released from jail or the hospital, we will have a two-way release of information on our website, have the patient sign it, fax it to us, and then you can sit down with the patient and give us a call. And the individuals that are pregnant, coming out of jail or coming out of the hospital, get first priority for getting a rapid intake here. And we will do those 5 days a week. And then like I said, if you are helping the patient make the call, we would like the patient to be present with you so that we can at least speak to them on the phone and confirm that they want to come to services. Clinics like this sometimes have a 50% or more no-show rate for scheduled intake assessments. So by verifying that a patient wants to come to us and making sure that they've got transportation and things arranged, when we're scheduling them for an intake, we're trying to reduce the number of no-shows that we get so that we can help as many people in the community as possible. Okay. Like I said, we want to open as soon as possible, hopefully later this month, and we will alert you all as soon as we know more. You can sign, if your organization wants to sign up for updates though, JamestownHealingClinic.org has an area where you can sign up. And we will send out an email alert to anybody who's on there too, as we have more opening information. All right, I know I talked super fast and went over a lot of things, but if you guys have questions, please let me know. And I'm happy to take them well now, although I think we're probably running out of my time. And but you can also email me or give me a call. I'm happy to speak with any of you.
I had a quick question, Molly. I was wondering about the term, you said medication for opioid use disorder. So that's
Yes.
MOUD.
Yes.
So the term or the letter, the acronyms MAT, those are kind of gone by the wayside, right?
Yes.
Yeah. Okay. We don't use MAT anymore. We use MOUD.
Yeah, yes.
Okay.
In the
Thanks.
eyes of insurance payers and a lot of longstanding programs, they still certainly use MAT. And I think patients a lot of times still think of it as MAT. There was a shift fairly recently going to MOUD because MAT for so long was used to imply that like treatment had an end date. Like it was kind of short term in the span of somebody's life, but we know that medications for opiate use disorder may be with somebody for many years. Makes sense.
Right. I read, oh,
sorry.
Go ahead, Laurie.
Sheriff Nole.
Yeah, thanks. Yeah, good job, Molly. And I don't know how much you had to do with moving this forward and stuff, but way to stick at it. I know it's been going on a while. I had a couple, hopefully they're just quick questions. And I was just curious, once someone gets all signed up and with the program, when they come for their dose, what's the average stay? I guess what made me think of this was the childcare. Did they just come in and get their dose and drink it and then go? Or do they have to sit around for a while or?
So it depends on the patient and what else they have to do. So they have to do at least one observed urine drug test a month. They have to go to at least one group counseling session a week. They have to, in the beginning, they have to meet one-on-one with their counselor once a week. There's a lot of other things that go into it, but if all they have to do that day is dosing, they can come in, they will probably be with us for about 20 minutes, and then they can head on out. And that's assuming that they're on a stable dose that hasn't changed and we already know how they're going to respond to it. If they get a dose change or they're a new start, they stay with us for monitoring for at least half an hour afterwards. But patients, if I had to estimate, I would say most folks on days where they have counseling or other things, which will probably be at least 2 or 3 days a week as we kind of spread stuff out, they'll probably be with us for about an hour and a half or 2 hours.
Okay, thanks. And the other thing I was wondering with this delay in your opening, does and I don't, anyway, does it have anything to do with the opposition, or is someone trying to hold it up still, or is that even?
I think we are just falling victim to the speed of the federal government, and that although we are in an opiate crisis, the individuals who have to like put that little number on our application don't see it firsthand. And I was ready to open this place in February. So
okay, thank you.
Yeah.
Any other questions for Molly?
I'll just comment real quick. If you have not had an opportunity to go visit Molly in her space in person, when you're talking about removing barriers and stigmas, Jamestown is doing it right. I encourage all of you to go see the facility and really see. It's a work of art. I was truly humbled and inspired when I saw it. So compliments to Molly in this work for sure.
Yeah, I agree. It's beautiful.
So I've got a quick question, Molly. Obviously, there's a difference between Suboxone and methadone and the way you can do that treatment. A lot of places do in-home induction or at-home induction with Suboxone. Is that something you'll be doing?
Most patients, when they come to us, have probably already tried in-home Suboxone inductions. And for whatever reason, it didn't work for them. I did primary care-based Suboxone for a really long time. And that I think the home inductions typically belong more on the primary care side or for like non-opiate treatment program settings. Patients, by the time they arrive to us, are going to likely need more observation. And the nice thing, like if somebody's going to start on methadone, the nice thing for them is that there is no induction. It is a full agonist medication. And so they don't have to go into that moderate withdrawal. Like once they come in, there's a dose that we can give them, and then they pretty much come back and we reassess them in 24 hours and we can give them an increased dose if they need to, or if the prior dose is working, we can keep them there.
So just to follow, are you gonna, I hate to use the word require, but encourage strongly that they get an SUD counseling at the same time as they're getting treatment?
They have to.
I have to. Okay.
Yeah, it's actually a federal requirement for us.
That's what I thought. I just wanted to make sure that's a best practice, right? So
yeah, it absolutely is.
Okay.
Other questions? Okay, thank you so much, Molly, for your time, and we really appreciate all of the work that's going on over there and look forward to hearing when it's opening.
Absolutely. Thank you, guys. I'll keep you posted.
Okay. And then moving on, I thought that we would look just briefly. I know we don't have a lot of time left in our agenda, but certainly at the intersection of behavioral health and harm reduction is the topic of gun violence prevention. And I thought we might just dip our toe into the topic with Sheriff Nole. And I put together, I worked with him to put together a few questions that we might start a conversation off with, and maybe it just ends up being this first piece of it and we talk about it more at the next meeting. But I'm going to turn it over to Sheriff Nole and pull up his slides.
Are you ready? Am I ready?
You're ready. Can you see
Okay.
it? Can you guys?
Well, it was kind of interesting. Lori got a hold of me on this topic of gun violence. I think it was a week or two ago, right in the time when seemed like there was a shooting happening every day somewhere in the country. And and trust me, whenever that happens, I, as a sheriff, and I think probably most law enforcement officers, you think, what would I do if that happened here? Or, why do we have to have this happening? What can we do to stop it from happening? So I thought it was good, something to talk about. It's something that we could talk about for hours, I think. But just to start off with a few, points of the landscape in Washington State. And one thing I can say is Washington State has some of the, if you want to say, strictest gun laws in the country. So anyway, what I thought I would do is just address some of these bullet points here, and then people can ask questions as we go along or jump in or whatever. So one thing that we wanted to get out there, what is a purchaser license? What purchaser license is required in our state or in our county? And the county doesn't have any different laws or rules than the state does. So it's all the same. So first of all, in 2019, Initiative 1639 was passed by the legislature. And it tightened up some of the requirements for this topic of, what do you need to get a gun? And it depends on what kind of gun it was. So prior to that, you had to be 21 to buy a handgun, like a pistol or a revolver or something. You had to be 21 and you had to have a background check. And a background check, the gun dealer, they actually go, if you live in Jefferson County and you go buy a gun, let's say at Sportsman's Warehouse in Silverdale, they send a notice to the Jefferson County Sheriff's Office, and we do a background check on you. We check our local records, we check the state database, the federal database, to see if you have any disqualifications like prior felonies, domestic violence convictions, things like that. So prior to 2019, all that was already happening if you were going to buy a pistol or a revolver, and you had to be 21. You could go into a store, a gun store, if you were 18 years old and buy a rifle or a shotgun. And if my memory serves you right, there was no background checks back in the day, if you want to say. So that in 2019, that also got changed. So to buy a semi-automatic rifle or shotgun, you also have to be 21, and you also have to undergo the background check. So that was a new addition to the law to try to combat the active shooters, school shootings, and things like that. With the background check, there's also a 10-day waiting period. And so, and an interesting thing about the 10-day waiting period is that when the sheriff's office gets a request for a background check on someone, we have 10 days to get that background check done. If we don't do it in 10 days, then the person automatically gets the gun. We pride ourselves on getting those done as soon as possible. It's a situation you never want to be in if someone gets a gun when they shouldn't. And by law, if we neglected to get their background check done in 10 days and they got a gun and then it came back saying they couldn't have a gun, we would have to go out and get the gun from them. And which probably wouldn't be a very fun thing to go do. So yeah, in Washington State, you have to be 21 years old to buy a pistol or a semi-automatic rifle, have a background check, and there's a 10-day waiting period. The next bullet point, what gun removals laws, permits, and bans exist in our state or county. Permits reminded me, so another thing I wanted to add for Washington State is if you want to carry a handgun concealed, that means like under your coat, in your purse, in your pocket, whatever, you have to have a concealed weapons permit. And that is something that you apply for at the sheriff's office. It also includes the background check and whatnot. Another interesting thing in Washington State and a lot of other states, Washington State is a state where it's called open carry. So if you wanted, you could just strap a big old pistol on your hip and go walking around town, and that's totally legal. So something to bear in mind. It's like a carryover from the cowboy days, I think. So as far as removing guns from people, if the deputies go to a domestic violence call and someone is arrested, we will take those guns for safekeeping if there's guns in the house. They go to the sheriff's office and are kept in the evidence room until adjudication, and then the person may get them back if they aren't convicted. When they go, it's interesting, to get them back, they have to go and undergo a background check all over again. So something could have happened in their criminal history, or another thing that's checked for background checks is any kind of involuntary commitment in a mental health facility for more than 3 days. So things can change after their guns are taken. So the guns can be taken on a domestic violence call. They can be, the judge can order that they be turned over to law enforcement for a protection order. There's a thing that came out a few years ago, the extreme risk protection order. A family member, law enforcement, someone can go to a judge and tell them that this person is unstable or they've made threats or whatever, and they need to have their guns taken away because they're going to do something dangerous. And a judge can order that, and we would go to the house and take their guns from them. Same thing, take them to the office. The courts would work out all the details on whether the person gets the guns back or not. If they said that they can't have the guns back, another little interesting point is, that it's their property. The guns are the person's property. So they can have their guns, they can give their guns to somebody else, and they have, write a letter or something, and then that person could come in and get the guns, and that person has to undergo a background check. What do we do in this county to support safe and secure gun storage? We have, and we still have, gun locks, cable locks that go on, but also in the 2019 1639 legislation, it pretty much says that you have to keep your guns in a locked safe, if you want a locked box or something that people can't have access to. So we don't have the funds to give out safes to people, but now you're supposed to keep your guns in a locked safe. And then, how is Jefferson County prepared for a possible shooting event? That's something that is just, like I said earlier, when I see the things on the news, that's always on my mind. What are we going to be able to do? We're going to be called on to do that. And being at the sheriff's office, being right near Chimicum School, we are trained we receive training to respond to those kind of events. And basically the training is that you go to, let's say it's a school, you go to the school, you hear where the sounds of the gunshots are coming from, and you go to it. Doesn't matter if you're there by yourself, doesn't matter, you don't wait for people, things like that. The expectation is that we will go engage that person to try to save as many lives as possible. So like I said, we receive training in that. We have provided training to some of the schools. We provided training at the courthouse to teach people what they should do in the event that they're all of a sudden you find yourself wrapped up in some kind of shooting scenario. And that's something we continually train on. Just this month, we have 2 of our sergeants going to, and there are firearms instructors going to some active shooter training. It's always changing. It seems like every time there's a shooting, the shootings are analyzed and the training is updated for the best way to respond. Another thing that makes that we've done here, just like with this group, how we all cooperate and help each other. We work with the local fire departments, the Department of Emergency Management. We get involved if we had a mass shooting incident. We work with the schools and also the Port Townsend Police Department, officers at the police department, and we train together. If something happened at the Port Townsend school or anywhere, Safeway, pick your location, the deputies would be responding right along with the Port Townsend officers and vice versa. So I just spit out a whole bunch of stuff, and I would also say that, feel free if you have questions or comments or concerns, you can always call me at the sheriff's office or email me. But I think that's probably enough for right now, Lori, unless you have any other ideas.
I want to open it up for questions, and I also want to note that at the link of the updated packet, there's an article that Dr. Karlbaum sent having to do with there's a group of surgeons, the American, now I can't even remember. Go look at it. I haven't had time to read it because he sent it just as I was putting together the packet, but there's some information in there that pertains to public health and how they might take gun violence prevention as an issue that's a public health issue. And so I know we are just dipping our toe into this topic, but I'd like to open it up for questions, thoughts people have now that we have Sheriff Nole and we have Chief Black here from the fire department.
I know that the hospital, we're charged with doing what's called ALICE training. Chris O'Higgins is in charge of that, and we have to do it yearly, and each module every year is a different one. And that has been, he's kind of been in charge of that. And that's been really good for the employees here. I mean, we have a large group of employees, but it's a big change from barricading yourself. And we're seeing that that's not working in the classrooms and other places, even the Oklahoma surgeon. So that's been really helpful for us at the hospital level to really, even my providers are required to take the ALICE training, and that has really helped throughout the organization. And I hope other organizations get on the ball on that, so that it's something like that. And then I really quickly, and I know we are running out of time, but in my beginning comment, I said disconnect between me and the hospital. I kind of insulted my team, Adam York and Dunya and Jake. I didn't mean any comment like that. What I was referring to is I'm new on this, and my behavioral health team, there's a disconnect between me and my team and how we get the information ourselves. They've been doing an amazing job at disseminating the information and doing this for years. This is new to me. So this is how I'm going to get the information. They've been giving us the information. It's just that how do I educate our team and everything else? So I think I hurt some feelings, and that was by no means my intent whatsoever. So I wanted to really clarify that, because these 3 individuals are amazing. And I wanted to really clarify that. So thank you.
Thank you for circling back on all of those spots, both the training and we're very glad to have whoever comes from the hospital here.
Okay. Thank you.
Having all of the people that we have at this table is so important to how we function as a collective unit for our community members. So it's good to have you here. Anyone else?
I just wanted to chime in on that, and that's exactly right. ALICE training, and that has kind of been advanced to what's called GAP training, but that's training for citizens, if you want to say, on how the best chances of surviving. And it's kind of funny in a way with like the Alice training when it came out. I remember when school shootings first started, and the idea was you barricade in your room, and my thought was always, no way, get out of there as fast as you can. And that's the idea now. Of course, you don't run towards where the shots are coming, but it's also the gap training, which is the same thing, but it's that gap of time, 5-10 minutes if you're lucky before the police get there. What are you going to do? Because you're going to be on your own. So anyway, it's I kind of hate talking about this because it's such a negative thing, but better to be prepared mentally a little bit than not at all. So anyway.
Sheriff, Chiefs, do you have you guys started any sort of TECC or tactical emergency casualty care training, or is there any multidisciplinary drills happening? I know in Clallam County, we had that big active shooter drill, and we kind of took that show on the road, and having all the stakeholders and doing those simulations was, incredibly beneficial. And we learned a lot of the nuances and problems. Is anything like that taking place? And then my follow-up question to that would be, are you guys still structured where EMS and fire is going to stage outside while contact teams go in? Or are you guys moving to a model that we're seeing best practices where, aid is actually following officers in and starting to apply tourniquets and address those, ABCs while the event is still hot, frankly? Have you guys started that shift, or is there any of that effort taking place? Just curious.
Well, I can say, I'm finding myself getting hung up on political stuff nowadays. But when I was first elected, we were really working with the fire department. We didn't do a full out scene, but we were doing tabletops where they had like a little city thing with cars and stuff, and we would all be on there with our radios and doing that. By the time it came time to really start doing, we wanted to do like a full scale scenario with the schools and EOC and fire department. COVID hit and kind of put everything on hold, and we're starting to pick back up with the schools and whatnot. But and I'll let the chief answer this. My understanding right now is that fire would wait on the boundaries while we went in and made it a warm zone where they could come into. But I don't know if you have anything else to add, Chief.
Yeah, we're not equipped or trained for that here, but in my recent past, all of the fire and EMS equipment had tactical body armor and helmets. And we would train every time there was a spring break or summer at one of the schools. We would rotate it up and do different scenarios, or at local warehouses in the Oakland Hills. Unfortunately, I thought I'd never have to deploy engine crews until the George Floyd riots, and we were sending strike teams into downtown Oakland. It was pretty dramatic. But I think there's been some work, to Sheriff Nole's point here, in the recent past, in the past few years, but ultimately we're not equipped or trained with the PPE. So we would never send a firefighter or paramedic into a hot zone until we could solve that.
And I know that
we have worked together. I mean, it's not like we wouldn't show up and go, oh, gosh, what should we do? I mean, we have worked on things and have, things planned out as well as they can be, because you never know exactly what it's going to be like when you get there. But it's not like, I mean, we work together on lots of things. It's not like,
sure,
I mean, we know each other and whatnot. So
well, and I know that, Chief McKern, you might be able to chime in, but I know that there's injury prevention grants available through the Northwest region. I wonder if there's some way to catalyze, even some sort of movement to maybe plan for some of that training, or buy, a select allotment that maybe the sheriff's department holds on to, or East Jefferson, or, where those vests can be deployed, that gear, and then as well as the TECC training. I can tell you it really made a palpable difference when we did that out in Clallam Bay. We did it in Forks. We did it in the city of Port Angeles at the college. And it really, it got our air partners involved. It really kind of, identified where the assets are that are going to come for transport, obviously with us and the fire service, but also watching, all of the law enforcement agencies interact and drill, I think was incredibly meaningful. So anyways, I'm just throwing that out there, but I do know that Chief McKern might have some resources on the region to help kind of facilitate some of that.
Hold that thought 1 second, Chief McKern. I want to say to folks, I know that we're at the 4 o'clock mark. If you need to drop off, we understand, but I'm going to hold the room open so that we can continue this discussion as long as folks would like to. Go ahead, Chief McKern.
That's okay. I'm going to follow up with Joey's comment. Yes, there is grant sources available through the region, but Joey, what I'd like from you, and we need to address this probably more so from the COP standpoint. When I mean that is the regional protocol has, I'm sure if you have a COP that has the MCI, because your MCI probably is different from ours. And if you could share that back with me in my email, send it to Dr. Carlbaum and to Colleen, so we can take a look at that as well. Because certainly the region's going to take a look at that, but they're also going to want to know, do we have a protocol in place that we're going to follow? So that being said, and Chief Black, you can echo in here, Blue Card is really heavy. They're into this now. I know that we're all Blue Carded. We've spent the last, that's one thing we did do an advantage during COVID was that we got everybody up to speed on Blue Card. And Chief, they do have a new module out there just for Blue Card and dealing with it. Now, I will say Chief Black and his team and Chief Brummel, when we had a couple events or potential events downtown Port Townsend, they did a phenomenal job of unified command, putting together an IAP, making it happen. And so that particular portion of it was there. I think you're right, Joey, in saying, I think we're just missing the tools. And hopefully we aren't going to get like downtown LA or wherever we went to, like Chief Black just talked about down in California. We don't want to get there. This is nice little quiet Jefferson County, and they're all going to listen to what Sheriff Nole has to say. And so certainly we want that to happen each and every day, obviously. But Sheriff, I'd love to talk with you offline, and maybe Joey, we can, if you can get me your COP, that would be great. And then we'll take a look at it at the EMS Council. Along
yeah, and it hasn't actually evolved to a COP. It's really jurisdictional between each fire agency, because not everybody's comfortable sending teams into a live event, and I think that chiefs are kind of not on the same page with that, right? Obviously, and I can understand both sides of the coin, but at the same time, best practices show if there is a live event, my kids go to the Port Townsend School District, sitting outside and staging, every minute, putting that tourniquet on, opening up that airway, that really every second counts. And so getting those crews inside, I think is kind of the future evolution. And so anything I can do to help for sure. And I'll send you over everything I do have.
If anything you have, and the last comment, Mark Apple, hang on, I'll get you right in there. The last thing, so too, Joey, the incident management teams, things have changed dramatically. And you've heard of the incident management teams, and we only do wildland. That's it. That's gone. By 2024, all the teams have to be CIMC qualified, and that's all hazard, whether it's WTO, whether it's riots, whether it's earthquakes, whatever it is, they've got to be able to help. And that's another part of that saving grace that we need to put in there as well. So hopefully I hope to answer your question. Sorry it takes so much time, Apple.
No, that's okay. I had another comment, but I'm just going to piggyback off of you, Chief McKern. I think what you just said is really valuable. And my addition to that from a public health standpoint is that the focus of emergencies and crises is the terminology used around that is different now. Public health is expanding. I mean, the crises that we have at hand are climate change and natural disasters. Then we also have, COVID crises, so diseased crises. And we also have a crisis of racism, crises of gun violence, all these things that we're talking about here that require a response. While we don't do any immediate going in response like you all do, there is a place for us at the table just with our knowledge and integration of what public health serves to do. And I would love, if anything through you, Joey, is being spawned here in terms of practices or run-throughs that we can partake in. We have someone on staff here who's a nurse who does many other things, but they also have a role in what's called emergency preparedness response from a public health standpoint. And they are new to their role, but not new to crisis in terms of nursing care. And I'd love to be sure that they are a part of anything you all are doing Jefferson County wise, just so that we make sure that all the points of the spokes of the wheel are engaged in that learning ongoing. And to that end, we also are trying to get updated here in the county on our our active shooter training. It did go into, dormancy over the pandemic, which, is not good. We should have been training annually anyway, but we're kicking that back in to gear right now through Department of Emergency Management with Willie Bentz.
Yeah, that's
Another
great
time
feedback.
I'll talk about the softer, slower ways that public health does harm reduction with regard to trying to mitigate or prevent gun violence, because it is quite fascinating. I want to be sure that this table understands that, but I'm not going to do it now since we have a few of us left, but it's a good conversation. I appreciate it. And I appreciate you all.
Yeah. And to be clear, my role is really, we're just a tool on public safety's tool belt in the healthcare system. So our role would really just fall in line with the chiefs who are going to provide that unified command, and then we're just a resource. But because I'm spread out, I can, offer up some of the work that's being done elsewhere and just be more of a supportive tool than anything else. So
I just wanted to add one more thing, and it's we ended on how do we prepare, but the original topic was kind of like, how do we prevent it? And I mean, if there's anyone that can come up with a plan to prevent gun violence, it's the Jefferson County Behavioral Health Consortium. So, yeah, what's going on in the world? Why are people doing this? Why is it happening so often? And it's like, and I guess, like Apple was saying, all the different things that public health has branched out into for, this crisis and that crisis and this crisis. But yeah, I'm not sure where it's gonna end, or is it gonna have a culmination of a really bad thing and it'll all be over, or I don't know. It's
well, and prevention to have impact takes years.
Well,
years and years. So it's daunting, and it makes me want to cry. And I'm not going to cry on a meeting right now, but I know it hurts everybody's heart on this call, especially you all who are first responders, in just for your face-to-face encounter that might be in your future, or that you've already responded to in the past. So anyway, it's good to talk about it, and I respect each of you. And I know it's a tall order, and there's so much work to do. It's hard to know where to start. But this forum and the respect we bring professionally to one another here that Lori entertains is, it's a great place to have some good thinking on these things.
Mm-hmm. And I can assure you that the Jefferson County Sheriff's Office, the Port Townsend Police Department, this is something that it's not just something that is in the back of our minds. This is something that we train on and try to prepare for. And I hope it never happens. One thing that always hits me on a lot of, especially like the school shootings, is that it's not like it's the majority of them aren't like in the heart of the big city. They're like out in the rural community. And I mean, that's Chimacum High School, Quilcene, and everyone's saying I would have never thought that would have happened here, but and hopefully it never does. But
agreed. And I do feel like everybody that we have at this table is part of whatever that long-term prevention and whatever that immediate ready for action approach is. And I'm really grateful that everybody's willing to talk about it, because it can be a complicated topic to talk about. And so I'm going to leave it at that. Apple, as you and I have talked before, I'm sure that there's an opportunity, at a future meeting to talk about sort of the softer ways that we're stepping our way into the gun violence prevention. It just seemed like we better at least get the topic opened, and there's always so much that I'm trying to pack into these meetings.
Yeah. Yeah, I know it can be hard to just sort of say, and now we're going to talk about gun violence, and we only have so many minutes left. It's a hard spot to be in, but just making the entrance available is the start. So that's good, and will be ongoing. Dr. Berry will be talking about gun violence at our next Board of Health meeting, which is always this third Thursday of the month at 2:30, and anybody's welcome. It's a public meeting. You can make comment in the beginning, and you can listen to lots of different presentations, one of which is about this from the good doc's perspective.
Now I can't shut up because you let us go over time. One thing I want, if you know Jennifer Moore, she's the chief civil deputy for the sheriff's office, but she's it's either this month or next month, she's going off to Alice training and to be an instructor. So for anyone on this meeting, if you know anyone, we are up for giving that training to any department, if QFC called and said they wanted it, we would do it. So if you, let me know if you hear of anything like that, if you want it in your agency, and we'll provide that, and, you know, free of charge, of course, but
I know you already said this, but could you repeat for me, Sheriff Nole, what sort of training happens in our schools right now? Or how often it happens?
It hasn't happened for a few years, but it was like the ALICE training, the GAP training, teaching the teachers, if something does happen, what should you do? You know, as opposed to before it was stay in your room and lock the door, to now, if you can, get out and get away. There's also, you know, with the GAP training, you may have to fight somebody, or you know, blockade, use your desk for something to get behind. You know, there's all kinds of, you know, what could you do in that horrible situation? So yeah, it's that kind of training. If you're in a grocery, you know, whatever your environment is, what's the most effective thing you could do to, you know, keep protected till law enforcement gets there.
Okay, good discussion. I'll see, I think I'm going to come around individually to folks and sort of see where we want to go next with it. What is the next piece we're talking about? And if there's anything that we need to start thinking about in terms of strategizing our own action in our community of next steps that we want to take, so that we're doing as much as we can on the prevention front and we're as prepared as we can be on the other front. And that's from the community side as much as it is from EMS and law enforcement perspective. All right. Thank you all for staying over. Go forth. Have a great afternoon.
Yeah. All right. See everybody.
Talk to you next time.